My name is Dr. Edward Ngwenya, and we will be continuing with our series of plastic surgery podcasts. And remember, this is just a succinct overview, high-level overview of the common plastic surgical pathologies and different topics that we cover. And the assumption is that there is already content. It's not to replace learning, but merely to supplement it. So just at a high level. Today we'll be talking about the lower limb reconstruction. So let's quickly go into the lower limb reconstruction. What's important for one to know is the anatomy of the lower limb. Very important to know the anatomy from the thigh, all the muscular anatomy of the thigh, the leg, the foot. Important to know the different compartments. We know we have 3 compartments in the lower leg. And that being the anterior, the 2 posterior, which is the deep, and the superficial, and then of course the lateral compartment, which houses the peroneal muscles of fibula, the longus and the brevis. So the patients with a lower limb trauma or defect will come in one of 2 ways, either acute, where you go to casualty, you're called by the casualty officer, the orthopod tells you that, look, there's a patient here who sustained a lower limb defect. Now that's one approach. And then of course there will be another form of presentation where this is a patient who comes in already in the ward, chronic presentation, maybe more than a week, or might be a patient who comes in after 6 weeks but has this chronic defect that is there. Now, how are we going to approach this? Perhaps this is a good opportunity to speak about the bite. Bite in 1985, 1985, gave a overview of how to approach these tibial or lower limb defects, rather, based on timing. And so he divided it into acute, which is immediate to 5 days, and these are usually, your limbs that are contaminated, but they are not infected. And then we've got the subacute, which is from 1 week up until 6 weeks. Now, these are the patients we don't want to operate. They have colonized wounds, infected wounds. So there we want to just merely treat with antibiotics, debride if we can, and we just want to make sure we don't operate on these patients in the subacute phase. And then the other group where we then operate, but on different principles, compared to the acute, will be the delayed presentation, and this is after 6 weeks. And those, the main point, they have limited infection, they have scarring, and so would need to then manage in terms of closing those wounds. Now let's look at this acute phase. Casualty calls you. Here's a patient who comes in post MVA with a lower leg defect. You go to casualty, you manage the patient as per the ATLS principles. After we've stabilized the patient as per our primary survey, we want to then determine if this limb is salvageable. And how do we do that? We have a MESS score, MESS score, that we look at to then tell us, is this limb salvageable? And that, of course, will look at the mechanism of injury. It will then look at high energy. Was it medium energy? Was it low energy? It would also then look at the ischemia. Is there pulse? and or is there no pulse? And what's the time frame? Is it more than 6 hours? Is it less than 6 hours? So that's one of the other things that it would then look at. Another thing that it would look at would be the presentation. If this patient is in shock, looking at the blood pressure, and of course, if you've got a hemodynamically unstable patient, it adds into this score. And then lastly, the age of the patient is another factor that would then be considered. And in essence, what we are looking at is, can we salvage this limb, or can we not salvage this limb? And once it's been decided that, look, this limb is a limb that can be salvaged, of course, by the way, the other factors that will lead you to amputating a limb are well described. In fact, if you look, I think it's the British, the B press that has a criteria for the limbs that would not be salvageable. Those ones then you look at, and we'll speak about it when we talk about amputation of the limb. So perhaps let's just quickly look at it, the decision to amputate. If you look at the Eastern guidelines, the indications for primary amputation would be tibia or sciatic nerve transaction. So those are the patients who have an absence or reduced plantar sensation at initial presentation. For them, according to the BPRES, they say, no, it's not necessarily an indication for amputation. But the sciatic nerve transaction and the tibial, that is an indication. Prolonged ischemia of more than 4 to 6 hours or muscle necrosis is another. Massive soft tissue injury or segmental muscle loss affecting more than 2 compartments is another indication. A Gastello-Anderson 3C or segmental bone loss greater than 1/3 of the length of the tibia is another indication. Severe contamination is another that's put there, and of course life-threatening associated injuries being the other indication for amputation. But this patient has come in, we've assessed as per the ATLS principles, we've stabilized this patient, we've assessed whether the limb is salvageable, and we've made a decision that the MES score is less than 7, and we don't have any indications for amputation, and we then say this limb is salvageable. So what is our next move? We then look at it in casualties, we open the wound, we classify our defect. There are 2 systems that we use, the Gastello-Anderson and the Bide-Spicer-Insini classification. The one that we generally all use is the Gastello-Anderson classification, which looks at bone and soft tissue. And succinctly, it just divides our defects into 3. Gastello-Anderson 1, the bone, it's a linear fracture, soft tissue less than 1 centimeter. Gastello-Anderson 2, it's a comminuted fracture, soft tissue 1 to 10 centimeter defect. Gastello-Anderson 3 is a severely comminuted fracture. There is bony loss, and soft tissue, it's more than 10 centimeters. However, we then divide it into 3. Gastello-Anderson 3A, where there is enough tissue to cover the defect. Gastello-Anderson B, where there isn't enough tissue, there's periosteal stripping, there's major contamination in that site. And then Gastello-Anderson 3C, where there's vascular injury. And so we've got this patient, and as plastic surgeons, we are usually involved in Gastello-Anderson 3B or C, where we don't have enough soft tissue cover. And so let's assume now we've got this patient who's got a Castello-Anderson 3C wound. What is our order of priority and treatment? So I see this patient in casualty. The next step that I'm going to then do, I'm going to quickly put a back slab to mobilize or stabilize the bone in casualty. Irrigation is something you can mention. However, just be aware of the controversies that exist that say, look, with irrigation, you may push debris into the wound. However, mention it, being aware of the controversies. But then the next thing is I take this patient to theater. Priority numero uno is bone stability in theater, where we will put an X-fix. Number 2, immediately we want to revascularize this wound. Now this is Castello-Anderson 3C. 3B, of course, we don't have to have that step then in place. But after we've revascularized, the next priority then for you as the plastic surgeon, we debride the wound in theater. And we will then cover the wound, and we would want to then come back, whether you cover it with a clear dressing, negative pressure wound therapy, you would see what guides you. But the point is you want to come back and debride within 24 to 48 hours. What is the ultimate plan? As per Gordina, in his article in the CME 2015, we want to make sure that we close this wound within 72 hours. Of course, when he presented his paper, he showed good outcomes. The better, flap failure rates, lower flap failure rates, hospital stay, infection, etc. when it was repaired within 72 hours. We are aware that there are others who've come and argued and said, no. Even if it's 15 days, we still get good flap survival. But we go as per Gordina, and we want to get cover within 72 hours. And of course, this is on a clean bed. Now, of course, we've dealt with Bide and his classification. Of course, now if we've got another scenario. So now remember, this patient acutely came. We've then sorted the patient out. They are ready for closure. We then will need to discuss the options that we have for closure. Scenario number 2, we have a patient who then comes in who requires, who comes in at a chronic phase, and the orthopods have cleaned the wound, and they now want, to request for cover. Now, this is a patient that you are then going to manage as per the time principles. This is a patient where we now talk about wound bed preparations. As per the time principles, we'll debride, we want a negative culture. Osteomyelitis, we want to make sure that we've got a handle over that. And this patient, now we are ready, we've got bony stabilization, and the plan now is to reconstruct, and we've reached that point. Now, what are our options for reconstruction? I'm going to keep this very simple. Of course, there are many other options, but I'm going to give you the practical options that will keep you more or less safe and more reliable. If you've got an injury, we divide our leg in thirds. If you've got an injury on the upper third of the lower leg, option number 1, as per O'Brien, I think that's O'Brien 1978. You'll just double check me there. But O'Brien said, use the simplest option as possible. And so the first and simplest options that we go for is a fasciocutaneous flap, a random flap. But we know that in the lower leg is a 1-to-1 ratio, but we know that Pontaine then came in. So what we do, we then put this, we can then apply a fasciocutaneous flap based on the Pontin principles, which is, of course, I think he initially spoke about a 2.5:1, but we accepted 3:1 ratio of raising the flap, provided 1, it's proximally based, 2, you include the fascia, and 3, it's based over an intermuscular septum. Those are the 3 conditions of the Pontin flap, the 3:1 ratio. And of course, when he originally described it, a wonderful article, if you can read, as free flap was, the way to go then. But he then, instead of grafting it immediately, which is something you can do, he would put a VEC dressing and then come back after 10 to 15 days and put a graft. And his rationale was there's less bleeding under the graft, so therefore the graft survival is better. And also it allows granulation to correct that contour deformity, and then a skin graft with better aesthetics outcome as per his findings and recommendations. So option number 1, upper third, is fasciocutaneous flap based on the Pontin principles. Option number 2, a perforator flap. But how are we going to put this perforator flap? Now, we use science. We don't just go blindly with a Doppler just looking where the perforators are. We've got some studies that have given us some form of understanding of where we can then find our perforators for these patients. And the place to then find one of the articles was in 1997 by Wetzel. And Wetzel spoke about the septocutaneous perforators being in specific areas. As per the anterior tibial, he saw that there were around the 3 septi 1, 2, 3, he named them, where there's about 6 to 14 perforators. And then with the peroneal, there was then septi 4, which had about 1 to 7 perforators, on average 4.8. And then the posterior tibial, which had 2 septi 5 and 6, it was is one that you can use as a guide. But also, I think it's Chavrin. I always struggle to pronounce this name, but Chavrin and Saint Cyr on the PRS 2008 then also elaborated and gave us, areas, reliable perforators where they found within 3 distinct 5-centimeter intervals. Where were those intervals? They said, look, from the bottom going up, 4 to 9 centimeters, then 13 to 18 centimeters, then 21 to 26 centimeters. From the intermalleolar line, those were the areas that they found good perforators around those regions. And so we know that with the posterior tibial, that is the best because we have perforators in all 3 levels there. The anterior tibial then follows, where we have it on the anterior, or the proximal rather, and the distal 5-centimeter regions that are there. And the peroneal, we have it on the middle region, which is 13 to 18 centimeters, using the intermalleolar line. And so that then gives you a guidance for you to then raise this perforator flap as the second option for an upper third defect. Now, what's our third option? Muscle flap is our third option. Which muscle are you going to use? I'm mentioning one and one alone, gastrocnemius. And the gastrocnemius, of course, we know the pedicle coming in from the sural as a type 1 muscle. If you don't get enough length and you want to lengthen it a bit, you release it from its origin, and that should increase the arc by about 5 centimeters if you do that. And you then, of course, reach it via a stocking seam approach. And the medial, well, it depends where it is, but the medial belly is usually the larger one, tends to have a better arc, but it depends where your defect is on which you're going to use. And then the last option is a free flap. And free flaps generally, it's an ALT, latissimus dorsiflap, free radial forearm or gracilis are some of the options that we can use. So option for upper thirds, fasciocutaneous, perforator flap, muscle flap, and then a free flap. The middle third, option 1, fasciocutaneous flap. Option 2, perforator flap. Option 3, muscle flap. But which muscle can we use in this area? Soleus muscle, best muscle you can use. Type 2 muscle, large, medial and lateral bellies there. So you can use a hemisoleus to be able to cover then your defect. And then the last option, if you can't, a free flap is another option. The lower third is the danger zone. That's the one we struggle in. The fasciocutaneous options we don't have there because we will be unable to skin graft, the tendons there, and we spoke about our perforators. So some may mention you can get away with a perforator flap if you propeller it. However, that's an area usually where you can go straight for a free flap. Now, there are other regional options, where you can use a crossover flap from the other leg, and of course a dermal matrix. And skin graft is something you should keep at the back of your heads. But of course, we are grateful for negative pressure wound therapy because it's assisted a lot in terms of wound management for some of these patients. So that's succinctly what you would do and how you would manage. And of course, if it goes down to the heel, some of the options for the heel, you can look at your sural, reverse sural perforator flap. Of course, issues are there with congestion, and the reliability there can be problematic. You're taking it on the perforators from the peroneal retrograde. And then the medial plantar artery flaps, lateral plantar, another option. But we'll speak more of those when we discuss foot reconstruction. Now, what is the last thing that we then do? We've stabilized the bone, we've revascularized the leg, and we've gotten soft tissue coverage. After the patient has healed and all is well, then you can come back for bone reconstruction at a later stage. And what options are there? If the gap is less than 4 centimeters, we can then put a bone graft, non-vascularized bone grafts. And then if the gap is bigger than that, then we can do a free osseous, flap. Where we then can use either a fibula or the iliacus or the scapula as a free flap there. Other textbooks will tell you if it's greater than 8 centimeters or 10 centimeters or 12 centimeters, but in essence, that's when you would then use it. Now, there is an option in between that you can use. And the books will tell you if it's between 4 to 6 centimeters, because you remember the growth is quiet. It takes a bit of time, per day, the amount of growth that you'll get. And this is your distraction techniques. And you can use 2 techniques there with your Elizarov techniques. I won't speak much into those. And then your musculate techniques that's described by Nelligan is another option where you put in that spacer, and then you've got the pseudo capsule that is formed by the capsule that was around that. You don't remove it. When you remove the spacer, you keep the back capsule, and then you put your bone graft and close that, to form that seal. So that's important in bone reconstruction. And there are elements that you need to know about with regards to bone healing, the phases that go into bone healing, the issues of osteoconduction, osteoinduction, osteogenesis, are some of the concepts that you can revise regarding that. But succinctly, that is lower limb reconstruction. I thank you for your attention, and I hope you found this talk useful.